Hello, everyone. I'm McFinn-Levere. Welcome to our Expert Talk Series. I just want to let you know that January the 10th was our 4th year of being of service to PALS. If you would like to join our research team, you could email us at info@everythingals. With your help, there's an answer out there and we can find it. So please consider joining our research. Thank you so much. Right now, I would like to introduce Indu Navar, the founder and CEO of Everything ALS. Thank you so much, Indu.
Thank you, McFinn. And I think I know a lot of you here, and it's really a pleasure to actually host today's speaker. The talk series, Stephen Goutman. And I, first of all, want to really thank Stephen to make time because his wife is expecting any day now, and we had to find the right time so he doesn't, have to run to the hospital that day. And, I'm really appreciative of his dedication and also having made the time today to come and talk to us. And a little bit about Stephen Goutman is he's an associate professor in the Department of Neurology and director of the Pranger ALS Clinic and associate director of ALS Center of Excellence at Michigan Medicine. And after obtaining a degree in neuroscience at Johns Hopkins University, Dr. Goutman completed his medical degree at the University of Michigan and his neurology residency and neuromuscular fellowship at Cleveland Clinic. He received a master's in clinical research design and statistical analysis at the University of Michigan. And as you can see from his background, he's been very focused on neuromuscular and ALS, and inspired by his patients, Dr. Goutman's research focuses on identifying new mechanisms and therapies for ALS. Specifically, he has been seeking to understand the genetic and environmental interactions that alter the susceptibility to ALS, especially in the state of Michigan, which has some of the highest rates of ALS in the country. With funding from NIH and CDC and ALS Association, he's discovering environmental risk factors associated with the onset and progression of ALS by collecting epidemiologic exposure surveys, biofluids from individuals with and without ALS. The ultimate goal is to one day make ALS a preventable disease. And Dr. Goutman serves as a site principal investigator of several multi-site clinical trials focused on identifying new clinical ALS treatments. He's an active participant at NEALS and has close to decades of experience leading ALS clinical trials at University of Michigan. With that, as a backdrop, we are honored to host you here, Stephen Goutman, and today's topic would be Unraveling ALS, the environmental insights ahead. And the stage is yours.
Thanks, Indu. It's really a pleasure. Let's see. Yep, I can change the slides. So it's a pleasure and an honor to be speaking. The work that you guys do is really amazing. So I'm in awe of your group. We had the opportunity to host Indu over the summer in Ann Arbor, and really what a great trip, and the things that you do and the community that you've created is amazing. So I really thank you for the opportunity to speak to you guys today about this topic that I'm passionate about. I have no disclosures relevant to this presentation, so I don't have to give a background about ALS to this group. What I'm excited to talk to you. So here's what we know about the incidence and prevalence of ALS, and I sort of put global in quotation marks because someone else is handling the admitting people, right? I think. Yep. Okay. So this is what we know about the global incidence and prevalence of ALS. So you can see all the dots down here are where we draw our numbers from for both the incidence and the prevalence of ALS. What you can see is we have a lot of work to do to understand this disease, not only in the United States, but really around the world. If we don't understand the disease, we can't make as many inroads into preventing this disease as we would hope to. In general, we think the incidence of ALS is around 2 per 100,000 people in European populations. And sort of non-whites, we think it's less common. But again, I contend that we really need to know more about this disease globally if we're going to make a difference. And here's what we know about ALS in the United States. New estimates is that the prevalence is somewhere in the range of 5 to 10 per 100,000 people. Just a few years ago, we were saying this disease affected people, about 5 per 100,000 people, and the CDC redid their numbers, came up with this, we'll use this capture recapture system, and said, well, potentially the prevalence is up to 10 per 100,000 people. Some would have contended that, yes, we've known that this disease is more prevalent, and the numbers just didn't reflect it. And others say, boy, there's a lot more work that we have to do. So we need to make inroads, and what's sobering is to think that the prevalence of ALS is expected to grow by 1/3 by 2040. And so there's really a fire under our behinds to figure out this disease more quickly. There's been some really interesting developments, I think, in the last few years about who's being impacted by ALS. And there was this really interesting article that was published in 2019. So if we think about the prevalence of ALS as 10 per 100,000 people, this study looking at veterans deployed post 9/11 was very fascinating, where they found an overall prevalence of ALS of 20 per 100,000 people. This agrees with our general thought that people who serve in the military are twice the risk of developing ALS. But what was really more interesting is that there were certain people in certain occupations in the military who had risks that were 5 times higher. So people in tactical operations or people that served in the Air Force were 3 times more likely to have ALS. Some really interesting numbers here that make us reflect on, what's different about these individuals. And then there was this study published in 2021 looking at the incidence of ALS mortality in individuals who competed in the NFL. And what we see is that this incidence ratio is greater than the general public. So what is it about playing in the NFL? We started this meeting off talking about our excitement about football, but there's something going on with football that's driving ALS. And we know through a lot of studies that there are these repeated themes about what's causing ALS. And in study after study, we see exposures like lead, heavy metals, solvents, pesticides, agricultural chemicals, trauma, and electric shock. We see these things over and over again. So we know that there are these risks that are out there. So why do we have hope? And I think one of the reasons we have hope of studying this goes back to Guam. So Guam, this island in the Pacific, and the US Navy went to Guam after World War II and basically found this ALS Parkinsonian dementia complex disease. It was an ALS-like disease, and the incidence of this was 50 to 100 times higher than what was seen in the United States. And this affected the native population there, and it really looked like a genetic disease because so many people had it. But there was no gene, there was no linkage to genetics, and it turned out that there was actually an environmental cause, which was felt to be likely related to the ingestion of this toxic cycad seed. And what happened is that as the diet changed and as this toxin was removed from the diet, the rate of disease declined really significantly and much faster than what could happen for a genetic disease. So I think this gives us hope that if we know what we're after, and if we can make the right changes and the right modifications, we have the opportunity to change the rate of this disease. So what I'd like to tell you today is, why are we so interested at University of Michigan about this ALS exposome? What's this idea of the gene time environment hypothesis, the type of research that we're doing, and then our future direction, our future ideal. So over the next 20 minutes, I hope to make you believe that one day we can make ALS a preventable disease. One of the things that we've seen, this is not a formal statistical analysis, but what we've seen in Michigan is that there are certain areas or regions of Michigan that have high rates of ALS. And if you sort of superimpose these maps on one another, you'll see that in these same areas are toxic emission sites. And so this gives us some pause and makes us say, is there something linking areas where you have toxic emissions emissions to areas where there are higher rates of ALS. Something else that gives me pause, this is a group of childhood friends that I took care of, and they went public. Here's their link. So they went public, but this was a group of childhood friends that all grew up on the same block together. You can see their home locations here. And they went on and all developed ALS around the same age, which is really incredible to think that there are these clusters. But we know about these clusters in Michigan. We hear about these clusters elsewhere in the United States, and we really need to do something about it. So there's this complicated road that people travel to eventually be diagnosed with ALS. And I know a lot of you are probably have that frustration that you or your loved one just didn't know what was going on for a long time before someone said this is ALS, and it's really frustrating. But what we know is that people have some susceptibility to disease. So these susceptibility factors are things like your genetics, your environmental exposures, your lifestyle factors. These in a sense sort of prime the pump to getting disease, and then eventually disease starts. And it's some really nice work by Michael Benatar and his group, really thinking about what are these stages or phases of getting ALS. We know that the start of ALS occurs well before the onset of symptoms. And eventually, as people go on, there's some biomarker evidence of disease, and then you start manifesting some possible signs or symptoms, and then eventually lead to a diagnosis. So one of the things that we need to do is really figure out what are these factors that make one susceptible to disease, how do we identify them, and how can we detect ALS early on based off of what we know about these susceptibility factors to either prevent or push off ALS. We know that genetics and heritability, so what I'm showing here is the fraction of ALS that's due to genetics, and let's not worry about the details here, but what I'd like you to recognize is that heritability, or how much your genetics contribute to one getting ALS, ranges from 20 to 60% based off of the studies that you use, meaning there's anywhere from 40 to 80% of factors that are unaccounted for in terms of the cause of ALS. And this brings us really to this idea of the gene time environment hypothesis, where you have this genetic load or genetic susceptibility to disease. Cells get damaged over time with aging, and if you accumulate a sufficient amount of environmental exposures, it can push one over the threshold to the self-perpetuating process of getting ALS. And this brings us to this concept of the exposome, which is really your cumulative lifetime exposure to toxins. So from the time you're born to the time you get disease. So it's really hard to account for everything that you've been exposed to from early on in life to disease. It is almost an impossible task, but it's a task that we're facing. And for those that are interested, we've recently published a review on the ALS exposome in Nature Reviews Neurology. So this idea of the exposome really started in the cancer literature by Wild, and this encompasses this life course of environmental exposures. And we see these exposures are broad: what you eat, the population around you, your lifestyle factors, your physical activity, your smoking use, the social factors, right? We talk about social determinants of health, chemicals that you're exposed to. These all play a role in this idea of the exposome. And one of the things that we've seen over the last decade is that we've learned more and more about the different aspects of ALS, the genetics, the pathophysiology, the links to inflammation. And now we're really beginning to focus on this idea of this exposome science. And so as we begin this hunt, should we be looking at ways of preventing this disease? Should we be on the hunt for ALS prevention at this point? And so one of the ways we go about doing this, and I think I saw some familiar names pop on this list here, is that we have a study where we basically invite all of the patients that we see at the Pranger ALS clinic at University of Michigan to join our biorepository. And this is an opportunity for us to gather information from people who are living with this disease, learn about where they lived, where they worked, what their hobbies were, what their hobbies are, types of activities they participated in military service, and also collect biofluids from them, blood and urine, and samples that we can use, really precious samples that we can use to create these linkages between disease and between exposures. And it's really, we have a really high participation rate. The people that we see are really generous in terms of giving up information and biospecimens. We really can't do this research without their support. So let me start with genetics, because as I shared that gene time environment hypothesis at the beginning, the basis is genetics. And we all know about these monogenic risks. So this is like C9. You have a single gene, and that's going to make you a lot more likely to get ALS. But the concept I'd like to talk about today is polygenic risk. You have these little hits across the genome, and as they accumulate, it moves one from, say, a low risk to a higher risk. And so this can begin to give us a background of where somebody falls in really this spectrum of risk. So one of the ways we looked at this was we looked at some of the people that we're caring for, and this was with help of my colleagues in School of Public Health. We looked at some of our cases versus our controls. We measured their genome, and we were able to find a combination of 275 changes in the gene that reflected somebody's susceptibility of getting ALS. And we see with this, what we call a polygenic score, that as we continue to think about basic traits like someone's sex, their age, whether or not they have a family history of ALS, whether or not they carry the C9 gene, we see that this polygenic score allows us to classify people in between case and control status in a better way. And in fact, as somebody's polygenic score moves from we call it a 1 standard deviation increase, but as it moves sort of along this standard statistical way of explaining differences in the means versus people who are in higher, who've kind of fallen to higher categories, we see that risk of ALS increases by 1.28 times. So this begins to form the basis of how we identify whether or not somebody is at a lower risk of having ALS or at a higher risk of eventually having ALS. And you may have heard about this multi-step model that people need to have a certain number of steps to get to ALS. If you're, say, a C9 carrier, there's fewer steps to get ALS. If you have a higher polygenic score, there's more steps to get to ALS. Another way to think about this is about genetic burden. So here are two people that have the same exposures over their lifetime. This is the threshold for getting ALS. If you have a low genetic burden with a threshold of exposures, or with a certain set of environmental exposures, you never reach the threshold. Whereas someone starting with a higher genetic burden, they're going to reach that threshold more quickly. Another way to think about it is two people with the same genetic burden. And so the person that has fewer environmental exposures never reaches that threshold, whereas the individual that has more genetic exposure or more environmental exposures or higher accumulation is really going to reach that ALS threshold. So what are the types of exposures that are out there? Back in 2016, we published our first look at what we call these persistent organic pollutants. So these are these legacy chemicals that are in the environment and essentially never go away. Their half-lives are in the decades, and we looked at a few categories: organochlorine pesticides, flame retardants, brominated flame retardants, and polychlorinated biphenyls, which were really added to all these products, and as for plasticizers and coolants and lubricants. All of these things are banned, although not in all places of the world. And in fact, these chemicals are actually detected in the North Pole, where they've never been used. And once they get into the environment, they last and they persist, and it takes decades for them to break down. And we continued to be exposed. So we looked at our cohort of individuals with ALS compared to healthy controls with the help of our colleagues in the School of Public Health. And I'm presenting a new cohort that we just published last year. And we see in general, I don't want you to get scared by these plots here, so I'm going to walk you through it. This dotted line here is the risk of 1, meaning if a dot falls on this line, the risk is basically equal between ALS and not ALS. So if this dot falls here, for example, PCB 28, it made no difference between being a case or having ALS or not having ALS. And we see in general that the PCBs fell a little bit to the right, but were not so statistically significant. The flame retardants again fell to the right, but the pesticides especially didn't really overlap with this non-significant line or this equal risk line. And this has been consistent with a lot of our studies. And furthermore, what we did was we developed what's called an environmental risk score. And this is really a way of summarizing your exposure to a lot of pollutants all at the same time. And you see that this environmental risk score really better accounts for the combined risk of all these exposures, because we're not exposed to one exposure, we're exposed to multiple things all at the same time. So we need to do a really good job of understanding what happens when you're exposed to multiple pollutants all at once. And in fact, what we see is as you move from the 25th percentile of exposure in our population to the 75th percentile of exposure, your risk of ALS increases by 2 times. So a really dramatic increase in the risk of somebody having ALS based off of their exposure. So we may say, well, does it matter that I have these pollutants? So it increased my risk of ALS. Do I still need to care about it? And we say yes, because one of the other things that we looked at was whether or not having these pollutants impacted somebody's survival with ALS. And this was a paper we published back in 2019, and we replicated these data again in 2013 cohort. And one of the things, or 2023 cohort, and what we found is that individuals that had the lowest level of exposure of these persistent organic pollutants, on average, lived about 0.6 years longer than individuals in the highest group of exposure. So this tells us that there are opportunities for us to be thinking about ways of preventing disease, ways of drugging the negative impacts that these pollutants have in terms of causing ALS, but potentially also tells us that we may be able to be using these same targets to slow disease down if we know what they do. And what we see is that people in the highest quartile of exposure, their mortality rate is twice that of those in the lowest exposure group. So it really makes a difference in terms of survival. One of the other things that we do is we collect information about where people have worked, where people live, their hobbies. And in an article or in a series of papers that we published back in 2022, we looked at occupational risk factors. So we asked people to provide us the different places where they worked and self-report the types of things that they're exposed to. And these responses all led to these exposure scores. So were you exposed to particulate matter? Were you exposed to volatile organic compounds? Were you exposed to metals? Were you exposed to combustion and diesel exhaust? And what we see in general is that people with ALS tended to report these greater exposures to these compounds in the workplace compared to people that did not have ALS. And you can see here that, for example, people who worked with metals, particularly for every 5 years of work, their risk of ALS increased by 1.56 times. So really dramatic increase in risk. And the other exposures that were really consistent were things like the particulate matter, the volatile organic compounds, and the combustion and diesel exhaust. And here were some of the other chemicals that we looked at. Interestingly, pesticides, not in all of our statistical models was it significant, but in some it was. So again, I think it continues to build that story that we talked about earlier, these agricultural chemicals and these pesticides. And so we also looked at different occupations, the types of work that you do. And what we found especially is that people who work in production occupations, so assemblers, fabricators, this sort of assembly line workers, for every 5 years that they worked in these occupations, their risk of ALS increased by 1.22 times. So giving us some idea of maybe what's happening or maybe what exposures are occurring that makes somebody more likely to go on to get ALS. We also saw, looking at these self-reported exposures, is if you said you worked with pesticides in the occupational setting, your survival decreased. And so we see here that individuals that reported working with pesticides in the occupational setting had a shorter survival compared to those who did not. and people who worked in production occupations and especially in military operations also seem to have a shorter survival. One of the other aspects that anyone who's filled out our survey knows is we ask what kinds of activities do you participate in? And this article was just accepted within the last week. And we see that individuals who reported within the 5 years before developing ALS, participation in activities like golf, recreational dancing. I don't understand what the exposure is there, but we see it. Gardening or yard work, hunting and shooting, and woodworking and weightlifting, these seem to have a higher association with having ALS. So it looks like people who are more highly engaged in these activities had a higher risk of going on to develop ALS for reasons that I don't fully understand at this point. Some could be exposures. If you're on the golf course, you may be inhaling or having contact with some of the pesticides or chemicals. Same with gardening or yard work. If you're hunting or shooting, there may be aerosolation of metals that you get exposed to. With woodworking, there's chemicals in the woods. Weightlifting, there have been risk that we understand linked to physical activity. These are all the possible factors that we may be seeing. And in fact, we also see that if somebody with ALS doesn't do these activities, but a family member does, that risk may also be greater as well. So maybe there's something about the exposures that are brought into the household that makes somebody more susceptible to getting ALS. So summarizing what I've talked about already in these last few minutes is that we see that your polygenic score gives us a baseline risk, that your exposures increase this risk further, that we can use exposure biomarkers to help us understand what somebody has been exposed to in the past and how that changes one's risk of going on to develop ALS, and that we can really use self-reported exposures to fine-tune our models and better understand who are people that are most susceptible to getting ALS. And so what can we do with this information? So we're thinking about prevention. There's been groups that are out there working on this. This was a working group that got together a few years ago. There was another working group over the summer, and I anticipate a white paper coming out about this, but we're thinking about ways of preventing ALS. So I see our work in sort of two parallels. One is working on identifying the risk that people have that are living with ALS right now. That's sort of that first parallel, right? We need to understand what are the possible targets and what are the things that we need to be looking out for. And then the second parallel is really following a group of people that we believe are at higher risk. This may be off of occupational settings. This is what I'm showing here, or people who have a family history of ALS, not genetic ALS, but have a family history of ALS. And what are the types of exposures that they accumulate over their lifetime? And at what stage or at what susceptibility windows do these make somebody more likely to go on to get ALS? And so we're about to launch a study that we call both My Brain, looking at exposures. We're focusing initially in Michigan. So this will really capture people who work in occupations that we believe are at higher risk of developing ALS, collect information about them, collect baseline genetic information, and get an idea of what their exposures are throughout the course of their life. In parallel, we're doing a study called Expose ALS, where we bring in people that have a family history of ALS and do these exact same metrics to understand what are the types of exposures that may make somebody more likely to go on and get ALS in the future. So I had 30 minutes to talk to you today. I took a quick walk through some of the work that we're doing. Really need to thank the people who've helped to fund our work, grants from the NIH, from CDC, from the ALS Association. Here's the wonderful group of people that I work with who really allow this work to occur. Here's our clinic group, our research coordinators that help care for our patients and really help engage the people that we see with ALS in our research projects. And it's really a blast being at Michigan and having the support of the university. So thank you very much for your attention and look forward to engaging with you guys.
Thank you so much, Stephen. That was amazing. And, a lot of the questions we ask about, how did I get ALS is the first thing we had to go through when my husband was, had his first few symptoms and we suspected. So this, you giving a little bit of window into your research and your dedication to getting more deeper into it. And I look forward to working with you more towards it. So with that, I think we have some questions that we will go through in our chat. And also I want to introduce my co-moderator, Martha Beach here. Martha, come out and say hi to everybody here.
Hello, thank you, Indar. I'm sorry, Indu. Thank you very much. It's been a pleasure and an honor to be here tonight. Dr. Goutman, that was a wonderful presentation. I have followed you for a number of years now. My husband was diagnosed in 2019. I'm a nurse practitioner and I've worked in the field of neuroscience for a number of years. So this is very near and dear to my heart, and went back to school actually to study ALS. And I know about your work and I'm honored to be here tonight to help facilitate the question. So thank you, Indu.
Thank you, Martha. And when she says she went back to school, she went and got her PhD. So that's what she means. So we're very excited to have this moderating session. So let me start with the first question. Do you have recommendations for an ALS diet?
Yeah, that's a great question. I don't. I'm going to interpret this question as what should I be eating to reduce my chance of getting toxins? And so what I'll say in general is that probably organic foods are a little bit safer than non-organic foods, treated with fewer chemicals. But we need to learn more. That's where we need to learn more, really get diet histories and things like that. But hopefully that answers the question.
Thank you, Dr. Goutman. Another question is your study open to people who are pre-symptomatic gene carriers?
Yep, so that's going to be our exposed ALS cohort, which is now sitting with our IRB right now, our institutional review board, waiting to get approved. And couldn't have it approved by the time I gave this talk, but yes. And so once that gets approved, my hope is that we'll get the announcements out there and give people an opportunity, if they have a family history of ALS, to really enroll and allow us to learn about these risk factors. Wonderful. We're going to be trying to use social media and other channels to advertise.
Wonderful.
So the next question is, if people actually have environmental exposure, do you recommend chelation or any IV, oral, any kind of method to look at the environmental exposure and elimination for ALS, people with ALS?
It's a great question, and one I get really frequently when I'm seeing people in clinic. We just don't have the evidence right now that tells us that that's effective. I'm not going to say that it's not going to work at some point or that there's certain strategies that we should be using, but we, as a physician, we like to formulate our recommendations based on the evidence that's out there, and we just don't have any of that evidence today that tells us that that's a strategy that's going to change disease course.
Thank you.
Thank you, Dr. Goutman. Another question is, have you noticed any common denominators when you're studying postmortem studies, what you're finding? Perhaps somebody could clarify that question a little bit more.
Mm-hmm. Do you have any postmortem studies that you're doing with the tissues to see the environmental overload?
Oh, I see. Yeah, so that's a goal of ours, is to really see if we're seeing some of these toxins in CNS tissue. And we have that underway, but we don't have any data to share.
Could I step in there for just a minute, doctor? They want my brain and my spinal cord within 12 hours of my death. I'm signed up for a local autopsy. Can you explain why that they would want to have that so quickly?
Oh, right. So, we know that every sample is precious. whether it be blood, whether it be urine, whether it be saliva, and whether it be the tissue that is most greatly impacted, which is the brain and the spinal tissue, the brain and the spinal cord tissue. That tissue breaks down after death. And so the sooner that's able to be transported to the lab and handled and managed in a way, it better preserves the integrity of that tissue. So that's the rush. Yep.
Thank you.
Great. And another great question, is there an opportunity to look at environmental impact on other neurodegenerative diseases as well, so that we can get the power of the analysis and, the pooling from the funding from other diseases? Could we obtain more conclusive set of findings that way?
So that's exactly our hope, is to really leverage this study that we're calling My Brain and make it more broadly about neurological disease and neurodegeneration in general, and to say, what is it that drives susceptibility to neurodegeneration, whether it be dementia, ALS, Parkinson's, whatnot. And we completely agree that ALS tends to be a rarer disease. Unfortunately, it has less focus at times, and if we can include other neurological diseases as well, it's going to give us more insight, be able to pool that power, and give us other opportunities to work with other groups to make this a more successful study.
Thank you, Dr. Goutman. I find this to be particularly interesting. I work for the VA, and we have a question: is the government studying why ALS is affecting our soldiers?
The DoD does have, they do, because the risk of ALS is higher in individuals who serve in the military, the DoD does have funding opportunities to really accelerate ALS therapeutics. Whether or not the government itself is doing research into this issue, I don't know off the top of my head.
I can speak a little to this. I do know it is a top priority among some of the clinicians, the physician clinicians at the VA, and I've been there almost 10 years, and I know that there are groups. I can't speak to, as you said, specific studies, but I know that it's a priority where there's a lot of analysis of studies going on in the civilian.
And I should also really call out the National ALS Registry. And I think one of the themes that's really important here is participation is critical, and signing up for the National ALS Registry is really critical to better allow us to understand who has ALS, what are the risk factors, more broadly. And so the National ALS Registry is a part of the CDC. I think there's actually a webinar tomorrow by Paul Maida about the National ALS Registry. So that is out of the government, and they both look at risk factors and also fund research, including some of our work. So there is some work coming out of the government, but whether or not DoD is doing it, direct work, I don't know.
So I think there's some question more on the diet and epidemiologic work. So there is some epidemiologic work showing that increased vitamin E in diet might be associated with decreased ALS incidence and progression. So, and with that, would you see a need for prevention studies that includes vitamin E treatment? And also there are some questions on alkaline water and cutting high fructose syrup, if those are anything that you've come across an association with ALS.
So one of the challenges here, as I noted earlier, is that it seems like there's just an infinite number of possibilities that can drive susceptibility. And so we need to figure out what are the top 10, the top 15, the top 20 targets, and turn our attention to those targets. sometimes we know what they are, sometimes we don't know what they are. And so our hope is to really allow some of the forms or data capture forms that we're using to allow us to understand some of the risks that we think are occurring today, things like pesticides and metals, but also give us the opportunity to see risks that we haven't even thought of yet. So could there be dietary factors? Absolutely. Could there be, certain areas of the country that have certain features about their water? Absolutely. We don't know those. We don't know those today, but we do need to figure it out. We have to narrow the focus. I think that's the biggest challenge is we have to narrow the focus. But we also have to make this research into environmental risk factors. We have to elevate it in our own clinic. We work to get more and more people involved in the research, and one of the things that we're trying to do is really make this research available to more people living throughout the country, so that we can better understand what's happening and what these risk factors are. I hope that makes sense. So I can't give any specific recommendations about those, about vitamin E or alkalated water, things like that.
And you probably get most of those when you talk about environment. So we really appreciate your patience here taking these questions.
Yeah, absolutely.
Yes. And so, Dr. Goutman, there's a question about, in terms of where we live, how much risk is involved with living near such as an asbestos plant? We have someone here tonight that says both their father and themselves have been affected by just a neurological condition, not necessarily ALS, recently. And what markers should they be on the lookout for? And then what are the chances that these individuals can be treated through these? What are the chances to treat these individuals through trials?
So this idea of clustering is really important. We don't have so we have to work on these mechanisms of reporting clusters and having formal investigations. And I think one of the things that's frustrating is that there is no formal mechanism where you sort of call in the ALS detective team and people descend in on an area and start sampling everything. I always encourage people to contact their state health department. The state health department can engage CDC and ask for help and really start looking into risk. So I think if you're seeing an area where you live where there seems to be a high amount of ALS and other neurological diseases, it's really worth reporting to your health department, because maybe there's some fingerprints there that can be chased down.
Great. I think, go ahead, Martha.
No, I was just saying, thank you. That's interesting.
Yeah, I think there is a lot of questions around clustering and siblings, or somebody in their family member who has been diagnosed with ALS, and what are the chances that, especially with the sporadic case, the chances of the siblings or somebody else in the neighborhood, in the same family, also contracting the disease.
It's a small risk, but we still want to know what to do about it. Probably the best data that I'm aware of come from the IRIS registry. This is Orla Hardiman's data, and what she's shown and her group has shown is that population risk of ALS is about 0.3%. If you are a family member, and if you're a family member and you've not been genetically tested, that risk is about 1.3%. And if you are a family member and there are no genes that have been identified in that family, that risk goes to about 0.7%. You have to double check me on those numbers. So that tells us that there is an increased risk, but it's not huge. Still, having said that, we still want to be able to reduce that risk further and really figure out what we can do to prevent ALS when it really comes out of left field, right? There's no family history. You're going about your day-to-day life and it just hits you for no reason or no rhyme or reason. That's the great challenge as well.
Thank you, Dr. Stephen Goutman. And with that, I think we'll conclude today's Q&A session. And thank you so much for taking the time. And like I said, you made this week happen. And congratulations and with your new member in the family who's going to join you very shortly here. And you've really touched a lot of people today with your dedication, with what you have shared with us. So anything we can do, we're here for you, and I talk for everybody from the ALS community here. So with your research. So thank you very much.
Thanks for having me. This was great. Thank you.
Yes, thank you.
Thank you.
And
I know you might have to go now, but we're going to stick around for another half an hour and chat about what you talked about and whatever anyone has on their mind. So once again, thank you.
Fabulous. Thanks so much. It's great to see everyone. Bye.
and have a great evening.
Have a good
You as well.